Okay, thank you. Good morning, everybody. Thank you, Ankit, for your kind invitation, and thank you for the panelists. Okay, let's talk about a scary complication of a reverse. Fortunately, it's not too frequent, but we have to know it. This is a patient, male, 81 years old, no great complications, grave pathologies, hypertension only. He came in our office 3 months after performing this reverse shoulder arthroplasty, and he came with the pain and loss of function. His pain is 2+, then a lot of pain, forward elevation 90 degree, internal rotation to lumbosacral joint, external rotation 30 degree. But he had deltoid pain and weakness of the muscle. This is, sorry, but this is the only X-ray that the patient said. He lost all his story. Then we perform CT scan. You can see this one with 3D that we performed every time, but we didn't see anything more than mesoacromion, okay, in this case. But if you perform, obviously, the axial view, you can see this complication, stress acromial fracture. When the first question is, do you have a lot of this stress fracture, something of this? And if you think that this implant can influence the stress fracture. And after we go to the question for the...
No, we have seen stress fractures in India, but the issue has been we didn't have these...
wait a moment.
We didn't have these newer designs till recently. So you're using a design which was very fixed, and it did not put too much stress on the deltoid, and there was not much of lateralization. So that problem was not there. Now that the Stryker and other companies are coming in, now you're seeing more of these.
Yeah.
If you look at your the component placement there, it's gone into varus. So once that happens, that's a 135, and you're actually putting it in varus. Even that increases the tension, the lateralization on the humerus. So that would probably put more stress on the deltoid and the acromion.
Yeah, I think it's very valid point here, because if you look at the AP view there, your GT is so far out of the acromion, so you have increased the lateral offset significantly. That must be either the 39 head there, I don't know what the base plate was, but that amount of lateralization, and again, this is the point we were discussing yesterday, you've got an inferior tilt on the glenosphere as well. So you've got worst of both worlds. You've inferiorized it, you've lateralized it so much, and that is going to put an extra stress on the acromion. And anecdotally, I moved from the Grammont to the Stryker Perform, and I think our incidence of stress fractures has gone up since we've been using it. Maybe it's a user error, we are lateralizing it too much, or possibly in the older osteoporotic patients, maybe we need to go back and doing not lateralizing it, or going back to the Grammont. I think this is what we have to look at.
This is very interesting. This is very interesting because the lateralization could be obtained for the stem, for the glenoid, for the central rotation, and after I see two studios, paper about that. But
you need to be careful when you're talking about lateralization, because this design concept is lateralized on the glenoid side, but it's medialized on the humeral side.
Sure. And
when you lateralize on the glenoid side, as opposed to lateralizing on the humeral side, you increase the resting tension on your deltoid.
Okay.
And that's this. So Mark Frankel's prosthesis, actually in the Mayo Clinic series, has got the highest incidence of stress fractures. And this is what every company is moving to, whereas if you look at the comprehensive, for example, it's lateralized on the humeral side and medialized on the glenoid side, and they don't have a very high incidence of stress fracture. So to kind of bandy around lateralization as a cause for stress fractures, that's not entirely correct.
Yes, I agree with you. This is anticipation of the literature, and this is a stem. Why it's not? It's in the middle. It's not real medialization, because it's a partial onlay, and this lateralize with the insert in polyethylene, because it's a medial stem, but it lateralizes after. But then we go to the discussion after. I want to know the first questions, and the first answer, that is, what would we do with this stress fracture? To treat or not to treat? Okay, conservative treatment, and most of all something would treat, and this is what we did. But the patients took a sling for 4 weeks. Then I performed physiotherapy. But the 4 March he came back with pain, and 9 months after the fracture we performed another CT scan. Another CT scan, and with loss of function, the same pain, the same deltoid pain and function and weakness. And this is the end of our stress fracture, a non-union, pseudoarthritis of the patient. At the end, we commented this time passed before the fracture and the control. Okay, this is a little bit too much. Then, now, I repeat the question. Now, what shall we do? The second. There are a lot of things more.
No, no.
They are the same.
The previous one.
No,
The
previous. The second one.
Yes.
Yeah.
ARS2. Can
The
you play,
second
can you play the
one.
ARS again?
Okay.
Yes.
There are two similar. They can restart to go to the same. It's the same.
Repeat this again.
Repeat again. Okay. Yeah, but are the same. You can revote. Okay. Single plating bone graft. Okay. Have you seen my presentation before? No. Okay. Okay. The same that we did with tibial allograft, single plate, and no revise the implant. We decided not to revise the implant because the patient is 81 years old, and we try to make the best for his pain. This is the post-op. This is the control in August after 4 months, and the pain decrease, the deltoid less of pain, and he regained the forward elevation and external rotation. And we are very happy, even if the screw was broken inside the treatment, because it's very strained. It's very straight.
Why was allograft used?
Because for this to help the healing of the non-union, as a tibial, when you put in fracture, when you put in the other side of the screw to retain the forces of the deltoid.
I mean to say, why autograft was not used?
So
Why allograft?
Yeah.
Why?
he has used it as a strut graft.
No, I understand.
For the structural, for the structural.
Why not use patient's own bone, autograft?
Patients.
Yeah.
81 years old. I don't like to take any more from these patients. I'm more than this. But we have in the Rizzoli in Bologna, we have a bank with a lot of this allograft from cadaveric people. Okay. And this is the August. This is the last day. I call him to take some photo for now. And this is the X-ray. You see the only axial view of the prosthesis we have is not well impacted, but if the patient now is gone well, even if the posterior deltoid is atrophic, instead the lateral and anterior deltoid was good. This is some video. The pain is only in sometimes told us. He reached the forward elevation 90 degree, external rotation 45, and no pain and weakness of the deltoid. Then if you remember the first slide of the patient when come to us, is the movement are similar, the same. We solved only pain and strength of the deltoid after 1 year. And then I want to provocate what you do to get better the movement or something else for these patients, or less him alone. The third one, please. Okay. Not too difficult. Yeah, I agree with you. Obviously, we are satisfied to leave him the pain and restore the force of the engine of the prosthesis of the deltoid, obviously. Okay, the discussion, I have some literature, but I want to discuss the first question of lateralization with this study. This is a SHA study 2021, is a review. He showed the rate of this fracture, but if you see primary and revision have the same rate of fracture, and the combination lateralized glenoid and lateralized humerus have less complication of fracture. Then is only one article that I show you after that say that if you put the combination lateralized glenoid and lateralized humerus, you have less complication in stress fracture. If you use medialized like Grammont style and glenoid lateralization of the humerus, medialization of the humerus, lateralization of glenoid, you have more risk of stress fracture, and it was this idea. Then this study, the I delta angle is the angle between the line passing from the surface of the glenoid and to the lateral border of acromion. This study with finite element on cadaveric show us as if you lateralize center of rotation, the humerus decrease the acromial stress. Then if delta angle is less this delta angle, less is the risk of fracture. Are you agree with this study? Is your common way of choose the prosthesis?
So, Dr. Mark Herner, what's your view on this, that both lateralized humerus as well as lateralized glenoid has less incidence of acromion stress?
I think the literature on acromial stress fractures is very poor. So even that study, the numbers of stress fractures are very, very low. So they've got lots of studies, and the numbers of, so actually coming up with a conclusion is very difficult. And I think generally speaking at the moment, I think we can conclude that the highest risk patient for a stress fracture is someone who's osteoporotic. So you've got to be very careful, and then you've got to, whatever you're doing, don't over lengthen, don't over lateralize, and be careful in those patients. There's a very good researcher in Australia, Sumit, who's actually showing now in his research that patients have already gotten a acromial stress fracture before you even do the operation. So they've got an area of increased stress in their acromion, and that's what's predisposing them to the stress fracture. Probably not what you're doing, unless they're osteoporotic or obese or whatever. But I don't think you can conclude anything from the literature at the moment on stress fractures because it's very weak. And one article that everyone quotes is with Alex Larderman. You know, and he goes, oh, if you lateralize on the one side, you're going to have an increase in stress fractures. And then if you actually look at his article very carefully, the majority of the articles that he actually looked at in his meta-analysis were on the ascent flex. And then he concluded that, you know, everything, if you lateralize, you have an increased incidence of stress fracture. But in fact, he didn't even look at other prostheses. He didn't look at the comprehensive or the new striker or the deltoid. So I think the only thing that I take home at the moment from this is the one thing I'm very wary of is osteoporotic patients. I'm very careful. If they've got an acetabularized acromion, I'm very careful in those patients. And then also, and this is data that I was given by John Sperling from Mayo, is every company now is moving towards lateralized glenoid and a 135. And there's a very, very good bioengineer who works for Exactech called Chris Roach. And if you look at the Exactech data, they've got a very, very big registry of over 10,000 cases. And they've got the lowest incidence of stress fractures. And they were the first people that came up with lateralization on the humerus and medialization on the glenoid. And then kind of Zimmer copied them. But they've got lateralization on both. And it's the one prosthesis that actually recreates the lateralization of everything. There are few, and one of them is the comprehensive. So I think I'm a little bit worried about a lateralized glenoid and a medialized humerus because the resting tension on the deltoid is very high, and then if you've got an osteoporotic patient, you've got a very high incidence. So that combination worries me a little bit. But again, the incidence of stress fractures is low, and I don't think you can read much into it.
Right.
Sorry.
No, I agree with you. It's not a definitive advice, use lateralize. You can choose your implant, but you have to pay attention to the different factors, like also the acromial, the deltoid lengthening with a posteriorly of the acromion, because it's the higher risk of the fracture. Then the literature shows us a lot of studies to do that we daily we don't perform also this idea for me, not only. Level classification, okay. In literature there is a lot of things. I want to show you the Mayo Clinic study published in 2024 they describe a stress fracture. They treated 16 shoulders for stress fracture, and they had the same result as our case. They told us fracture fixation in stress fracture, non-union, provide to pain relief, but only modest improvement in motion and functional outcome. Then they told us, say to the patients, if he had a non-union of a stress fracture, the prosthesis can go as before, but we treat only the pain, only the fracture, only the pain and the weak and the strength of the deltoid. And also this meta-analysis confirmed that conservative treatment for stress fracture is not the option. Is not the option for regain movement or something like that. Then our algorithm in Cattolica is acromial fracture, displacement, yes, no, yes, surgery, no, we try, obviously, because we are in Levy zone 1 to 2, then we can stay moderately conservative, but after 1 month, not 9 months like we do for this case. CT scan, this fracture is healed, yeah, you can continue physiotherapy, is if no healing, pain, surgery. Thank you.
Thank you. Thank you, Dr. Antonio.